I'll share my screen.
Yeah, sounds good.
You gotta do the, oh wait,
The green thing.
the green thing. Yes, exactly. Hi everyone. I'm really excited to be sharing this time with you guys this morning. Today I'll be presenting about osteoporosis, and I felt a lot of pressure with this talk because there hasn't been an academic half day on osteoporosis for a very long time. So I thought it would be a good refresher for all of us, kind of lend a general internal medicine lens on this topic that really cuts across endocrine, nephrology, rheumatology, and osteoporosis is kind of like this ethereal thing that no one really owns, right? Because it's managed by so many different disciplines. So today I'll make a case that this is a primary care topic, and I think it should be owned by general internal medicine. But before we do that, let's gain a little more of a nuanced understanding of the mechanisms of osteoporosis, and therefore it'll guide our understanding of management for osteoporosis. So in terms of my learning objectives for today, we'll take some time to define osteoporosis. I'll share some of the epidemiology and public health perspectives on osteoporosis. We'll talk about the screening recommendations that exist for osteoporosis. We'll go over some of the risk factors for osteoporosis and some of the things to consider when you're thinking about who to screen for osteoporosis. We'll talk about strategies for primary prevention, and then review the many treatment options that are available. So starting off, how do you guys define osteoporosis? Throw it up in the chat. What's your definition? Okay, so I'm seeing a lot of definitions based on T-scores and low bone density, fragility fractures, great, bone density, risk of fractures. This is great. Okay, awesome. So in terms of formal definitions of osteoporosis and other relevant terms, osteoporosis is a disease of impaired bone mass and bone strength, the bone microarchitecture that predisposes to fragility fractures. So notice that it's not, osteoporosis isn't just defined by low bone mineral density, which is kind of like what we clinically seem to associate it, the characteristic the most. But bone strength is pretty multifaceted and related to other things like bone turnover and resorption, the anatomy of the bones themselves, so the size and shape of bones, the degree of mineralization of bones, which can contribute to bone density. But then there's like, a point where over mineralization of bones increases your risk of fracture. So again, like, there's a balance there. And then the microarchitecture of the bones. Fragility fractures are defined as a fracture that's sustained from low energy trauma. So low energy trauma is the equivalent of a fall from standing height or less, so like a ground level fall. But other fragility fractures are, like a vertebral compression fracture is a classic definition of one. And, the classic story is a little old woman goes over a speed bump in her car, and that little degree of trauma of going over the speed bump causes her to pop a vertebral fracture. So that's the kind of embodies that low energy trauma. Osteopenia is, on the spectrum towards osteoporosis, and it just is defined by lower than normal bone mass. But we know that osteopenia may meet criteria for treatment and may meet the clinical definition of osteoporosis based on the patient's risk factors for fracture. So here's a nice graphical representation of osteoporosis that, it kind of shows you the bone microarchitecture that I was talking about earlier. On the left, there's like young, normal, healthy bone. You can see that, it's like this nice organized structure that lends stability and to the bone. Whereas osteoporosis, yes, there's decreased mass, but there's also like these holes that predispose to fragility, and that you can see in the microarchitecture. That's much more likely to collapse. It's not just breaking in half. It's that collapse that really adds risk. And Tree, just let me know if anything's coming up in the chat. I'm not able to see.
Sounds good.
I'm struggling with this green box. Okay. Epidemiology. So osteoporosis has a pretty large, significant public health burden. So 10 million people at any given time in the US have osteoporosis, and then an additional 34 million people of those are at risk for having osteoporosis. These are mostly older people, mostly our geriatric population, but we'll talk about reasons to think about osteoporosis for younger people. In terms of like the public health burden that comes from osteoporosis is mostly related to the morbidity and mortality associated from fractures and the healthcare costs that are associated with fractures. So every year there's about 1.5 million fragility fractures, and you guys can think about like what an expensive hospitalization that is. That's orthopedic surgery, that's physical therapy, it's, a prolonged hospitalization, and then very prolonged rehabilitation course after a fracture. The lifetime risk of fracture for women starting at the age of 50. So a 50-year-old woman at the beginning of, at the age of 50 will have a 1 in 2 chance of having a fracture during their lifetime. So there's very high burden. This chart here shows your risk of 10-year fracture by age, and you can obviously see that goes up over time. If you're 80, you're very high risk for fracture. But it also kind of exemplifies this cumulative risk that happens. So just like by virtue of your age, your risk goes up. You'll notice that the risk of fracture for men is less, but maybe a little more than a lot of us realize. So like a man at the age of 50 will have a 25% risk of fracture in their lifetime. And then, the 10-year risk of fracture for a 50-year-old woman is about 10%, and that's their same risk of breast cancer at that age. So, a lot of people in the osteoporotic field say like, oh, this is something we should be more actively screening for because of the significant quality of life issues that are associated with it. So a little bit of an overview of fragility fractures. So the most common sites for fragility fractures are vertebral fractures, hip fractures. Those are the ones we think about the most, but also think about wrist fractures. So your classic story of a foosh, like a little radial ulnar fracture, humerus fractures, rib fractures. And then again, these occur with low energy trauma. Some notes about these 2 specific types of fractures. So vertebral fractures, you guys have all had experience where this is like a common incidental finding that we'll notice on radiology, and it's often not communicated to patients. A lot of times patients will have no idea that they were incidentally found to have a vertebral fracture. Only 40% of new vertebral fractures will manifest with pain. So that means like over half of vertebral fractures are clinically silent. That doesn't mean that they're not manifesting in some way. So a lot of people will have like occult height loss that suggests that they've had a silent vertebral fracture. And then vertebral fractures are important to be aware of, important thing to maintain on a patient's problem list, because the risk of repeat fracture is so much higher than someone with equivalent demographics and bone mineral density. So it's just like a very key prognostic factor for the risk of fracture in the future. Hip fractures, like I already alluded to, huge source of morbidity and mortality, particularly in the geriatric population. It's also like one of these key life events that can affect people's ADLs. So one half of people after a hip fracture don't regain independent living. So we all know this, like in the hospital, like, we're going to discharge this patient to a SNF, but it just meaningfully affects this patient's quality of life and their ability to live their life in the way they want to. And then hip fractures are like a huge source of mortality for geriatric patients. So some studies in older studies estimated the 1 year mortality after a hip fracture being 37%. So it used to be the thinking that like after a geriatric patient had a hip fracture, 1 in 3 would die within the year. This mortality rate has been improving over time, and a lot of that comes from more aggressive PT, more formalized mobilization efforts. Like after orthopedic surgery, there's some data that medicine consults. So all of us holding it down on Harborview Jerry, you can know that you are probably contributing to a reduction in mortality after a hip fracture. So this is a little diagram that I created about the continuum of care associated with osteoporosis. So thinking about, how a patient presents with a diagnosis of osteoporosis. So either you'll screen for it or you'll discover it with a fragility fracture that leads to the diagnosis of osteoporosis. And then after you arrive at that diagnosis, there are three things that happen and often happen together. You'll discuss lifestyle modification, you'll discuss medications, you'll discuss any reversible comorbidities that are contributing to osteoporosis, and working on those things in tandem. And then we'll think about reassessing treatment response, and then circling back for any additional modification. We'll talk about lifestyle modification later. So in terms of screening recommendations for osteoporosis, the USPSTF recommends screening all women 65 and older with a DEXA. I think a clinical question that comes up for me sometimes is, should I be repeating this for like much more geriatric patients? So I did it once at 65, and is there a role for doing it again and when they're 70? So there's small studies that show there's no benefit to repeating screening 4 to 8 years after initial screening. So if a woman's had it at 65, you can consider, and they have a normal DEXA, you can consider repeating a DEXA like after that 8-year mark, like when they're 75. Or if there's been a meaningful change in their lifestyle, in their level of physical activity, or say they've been put on a bunch of steroids for some other disease, those would be reasons. Like if their medical disease has changed to the point where you think their bone mineral density has been affected. Other circumstance that would come up is like, a man who's been put on androgen deprivation therapy for prostate cancer. That would be a reasonable change in their medical care that would warrant repeating a DEXA. And the USPSTF also recommends screening women younger than 65 based on their clinical risk assessment. For us functionally, that clinical risk assessment is the FRAX, which we'll talk about in a little bit. Notice that the USPSTF does not provide any screening recommendations for screening men. So there's no consensus about like how we should be screening men for osteoporosis. In terms of geriatric practice, a lot of the geriatricians will just go based on FRAX, or based on, just age, like anyone above the age of 75 is reasonable to screen if they have a low BMI and that sort of thing. Okay, so let's do a little poll. Tell me which of these patients does not have osteoporosis. So utilizing our definitions for osteoporosis, who does not? While that's going on, I'm going to fix my green box. Okay, maybe we can share. Okay. Okay, great. So most votes are for B, some votes for A and C. So the correct answer here is C. Answer choice A, this is the little old lady that my friend who's an ortho resident took care of like 28 times after the ice, like a bunch of foosh on the ice over the holidays. She definitely has osteoporosis. Answer choice B. So thinking about T-scores and Z-scores. So a Z-score is bone mineral density that's normalized to your age. So if you have a low Z-score, less than 2, you probably have severe osteoporosis because your bone density is poor even after normalizing to your own age. So answer choice B has probably severe osteoporosis. Answer choice C. So a stress fracture is not low energy trauma. It's actually high energy trauma because you're like exercising the crap out of your bones and that's leading to a fracture. Answer choice D is someone who meets normal screening criteria for osteoporosis, a T-score less than 2.5. And then answer choice E. So based on the FRAX, we'll talk about there are certain percentage thresholds that define osteoporosis. So here is all that information again, more clearly laid out. So you can diagnose osteoporosis with the presence of a fragility fracture based on a DEXA that shows a T-score less than 2.5 standard deviations. And a reminder that the T-score is standard deviation difference compared to young adults. Whereas a Z-score is standard deviation difference compared to age-adjusted population. So if you have a low Z-score less than 2, that strongly suggests that this person may have a predisposing condition that's contributing to osteoporosis, that they probably have more severe osteoporosis for which there's a secondary cause. And lastly, osteopenia with an elevated fracture risk can diagnose you with osteoporosis. And this is based on a 10-year probability by FRAX of greater than 20% for a major osteoporotic fracture, or only 3% of a risk of hip fracture because of the morbidity that's associated with hip fractures. There's a much lower threshold to warrant treatment. So some notes about DEXAs. So a DEXA is a dual-energy X-ray absorptiometry. DEXAs measure bone density, but they don't measure bone quality, bone microarchitecture, or bone turnover. And when you're comparing between DEXAs, you can only effectively glean anything when you compare between a DEXA that's obtained by the same machine manufacturers. So there's like 2 machines that we use at UW Medicine. There's like a Hologic and then one other type. And you have to check like the manufacturer if you're trending DEXAs. The reason for that is manufacturers use different methods for creating the photon beams that they define bone density. They use different detection algorithms to define the edge of the bone. They use different algorithms that incorporate different assumptions on body size and tissue composition. They're just fundamentally calibrated differently. So all that to say, like if a patient has a DEXA on 2 different machines, it's very hard to say like if there was a change in their bone density or it was just the machine itself. And then I think a lot of patients ask me like how much radiation are they going to get with a DEXA? So it's actually very, very low. To the point is comparable to daily background radiation. So that was like pretty practice changing for me. Like I feel like sometimes I'm like, oh, I don't know, like we can spare this person this radiation, but if it's going to be mildly clinical informative, it's worth ordering. I guess you should also think about the cost of it as well. That's there. So another, are you guys seeing these like little like green boxes around it? I don't know. So another thing you can order with your DEXA is a vertebral fracture assessment. So this is an additional test that you order with your DEXA that screens for vertebral fractures along with along with your DEXA. The reason to get this is to know if one of your patients has a vertebral fracture, because we know that so such a large percentage of vertebral fractures are clinically silent, and it's such an important thing to know prognostically for their osteoporotic risk. So think about ordering a vertebral fracture assessment if a patient has clinical evidence of height loss or reported evidence of height loss. If they say, like, I think I might have fractured something because of this trauma, that would be reasonable. Or if they have a low spine T-score, so that increases their risk for a vertebral fracture. So a little equity spotlight on the FRAX. So the FRAX is a tool that was created at the University of Sheffield, so in England, to estimate 10-year probability of fracture for untreated patients, and it utilizes a bunch of clinical risk factors and their femoral neck bone mineral density. The data that's utilized in the FRAX is derived from large prospective studies, and it does comprise a worldwide aggregate patient population. And then the FRAX utilizes country-specific algorithms. So there's a UK FRAX, there's a Canada FRAX, there's a China FRAX, and US FRAX. So the US FRAX is stratified by the race of the patient. And they use these 4 very broad categories of white, Black, Hispanic, and Asian. Note, there's no Native category, Pacific Islander category. And you guys all know this, race is a social construct, and even self-reported race, it's very hard to put this patient, if you're seeing a patient into one of these like very 4 non-descriptive categories. And there are studies that show bone mineral density variation is greater within an ethnic population than across ethnic populations. So there's a lot of controversy in the field of osteoporosis, like why we need these 4 categories. Other countries that use race-based categories are China and Singapore, but Europe doesn't use race-based categories. Canada does not, and Canada has similar racial diversity as the US, and somehow they're able to clinically use this effectively. So, the equivalent bone mineral density confers different fracture risk, and race is not a good surrogate for like those factors that confer risk. So it's just often a proxy for BMI, which is not an effective clinical tool, and we should just use BMI. Another equity lens for this, so thinking about disparities that exist in osteoporosis. So just in general, screening for osteoporosis is low for all comers. So only like about 1 in 4 women who are eligible for screening actually get it. The screening rates are much worse for Black women. So 40% less screening that occurs for Black women. So even though Black women are statistically less likely to fracture than white women, they have a much higher 1-year mortality when they do fracture. And then Black women are much less likely to receive treatment for osteoporosis after they're diagnosed. Less than half of Black women are offered appropriate treatment after they get osteoporosis. Okay, so which of the following risk factors is not associated with osteoporosis? And just answer choice A through D, guys. Okay, so everyone's on the same page that obesity is the one thing that's not associated with osteoporosis, which means that celiac disease, alcohol use, sickle cell disease are all associated with osteoporosis. So interestingly, obesity, we know the exact opposite, like low BMI is associated with osteoporosis, but some features of metabolic syndrome are associated with osteoporosis. So let's go over that. So the 6 risk factors for osteoporosis that are incorporated into the FRAX are your age, exposure to glucocorticoids for long periods of use, low BMI, family history, smoking, and then alcohol use. In terms of medical diseases that predispose to osteoporosis, so I think all of us are familiar with like rheumatoid arthritis being like a classic association with osteoporosis. CKD, mineral bone disease, is really complex, and there's features of osteoporosis, but it's actually maybe a more distinct clinical entity than just, the osteoporosis we see in the healthy population. Diabetes is associated with bone metabolism, and insulin resistance can affect bone growth and resorption. Hypogonadism and relevant clinical entities, specifically like opioid use disorder, predisposes to osteoporosis. And then, thinking about hyperparathyroidism, both primary and secondary, IBD, sickle cell disease, you can have this microvascular, sickling that affects, the vascular supply to the bone that increases risk of osteoporosis, like avascular necrosis, celiac disease, cystic fibrosis. So a lot of things to be mindful of, and these are the patients that you should think about screening potentially earlier for osteoporosis.
Anisha, we have a question in the chat.
Yes.
From Nikki Zarling. Sorry if I missed this, but do FRAX changes based on race increase or decrease the T-score?
Mm-hmm.
Like in comparing a Black versus white woman, does it increase or decrease threshold to treat per guidelines? Just curious.
So for a Black woman, it often decreases threshold to treat because there's like an assumption that, there's like a problematic race-based assumption that Black bones are stronger than white bones. So that increases, the disparities that are prevalent in osteoporosis treatment. Cody's asking, do you know if history of Roux-en-Y increases risk? So similar to the spectrum of like IBD, malabsorption in general can increase your risk of osteoporosis. There's some other risks associated with gastric bypass that I'll go over later. Do the aforementioned predisposing conditions affect the screening recommendation? So yes. So again, the USPSTF is a little vague about like who you should screen before the age of 65. But these conditions, and some more than others. So like if we screen everyone for diabetes like before the age of 65, it wouldn't be a cost-effective use of DEXA. For people with primary hyperparathyroidism, that's something you should definitely be screening for earlier. The CF patients, IBD, those conditions that have more like absolute risk for osteoporosis, you should consider screening them earlier. And all these risk factors are cumulative too. So like some of these patients will be at higher risk for premature or ovarian failure. There'll be like a hormonal contribution as well. So that cumulative risk is what should inform your decision to screen earlier. Thanks for the questions, guys. Okay. So in terms of lifestyle modification, I was never really comfortable, like, what am I supposed to be telling patients to do after I diagnose them with osteoporosis in terms of like the medications, I'm pretty comfortable with that, but like what in terms of lifestyle, aside from saying like eat more yogurt? So the goal for calcium intake is 1 gram to 1.2 grams a day. And certainly eating more yogurt is a reasonable recommendation to make for your patient. But there are other sources of dietary calcium that you can recommend for patients. And there are these great like USDA lists that show calcium content in food. In terms of vitamin D goals, so your goal range is 20 to 50. A lot of people will overshoot this goal. So a lot of patients will end up with like vitamin D levels in the 60s, 80s, 100s. Like hypervitaminosis D is a really common clinical entity with like how prevalent supplements are now. there's evidence that shows like if you overshoot this goal, like hypervitaminosis D increases risk of fracture over time because you're like over mineralizing the bone, which makes the bone too brittle. So you want to keep people at this like sweet spot of 20 to 50. The way you do that is with a vitamin D supplement of 800 to 1,000 IUs daily. Y'all might have seen, these regimens of if someone's like severely deficient, then you should replete them with ergocalciferol, 50,000 units weekly for 8 weeks to kind of catch them up. And that's like heavily utilized clinically, but there's no evidence to suggest that that's efficacious. So if like prescription for ergocalciferol is like not attainable for your patient, or they can't afford it, or whatever, there's no reason to push for the ergo 50K regimen over just like 1,000 daily to catch them up. In terms of like the formal recommendations for weight bearing exercise, so they should exercise 30 minutes 3 times a week, so 90 minutes total a week. And what defines the weight bearing exercise? So weight bearing exercise for a geriatric patient is not sitting. So anything that's making them mobilize on their bones, exercise their bones is great. So walking programs are evidence-based, that's great. Tai Chi is a really great option for older patients, not just because it's weight-bearing exercise, but it also has evidence for fall prevention, which is the next thing that you should be talking to patients in terms of lifestyle recommendations. So fall prevention, it's a very complex topic and could have its own lecture on its own. But that comprises like evaluating the patient's home environment to like eliminate all these like things that cause them to trip or sharp corners for them to navigate, evaluating needs for assistive devices, mitigating any medical contributions to fall, so like neuropathy, neurological diseases, syncope, that sort of thing. And then physical therapy for balance and strength training. That's another reason why the osteoporotic world really likes using Tai Chi. With regards to osteoporosis medication, so we're going to switch gears to the actual meds that you guys will prescribe. So the framework for thinking about medications is there's 2 major buckets. There's anti-resorptive therapy, which is medications that interfere with like the physiologic or pathophysiologic resorption of bone. And then there's anabolic medications, which actually help build bone. So we'll drill into those 2 categories now. So bisphosphonates. So this is like the workhorse of osteoporosis medications. Like all of us are prescribing alendronate for our patients, and that's for a reason. The mechanism of action for bisphosphonates is that they inhibit the osteoclast bone turnover, which results in a net gain of their bone mass. So you basically get in the way of osteoclast resorbing bone. Before you start a bisphosphonate for a patient, you should make sure their vitamin D and calcium replete. You should ensure their creatinine is appropriate for bisphosphonate therapy. So the labs you should draw is a BMP and a vitamin D, or a renal function panel if you want to check a PTH. Contraindications for bisphosphonates. So a lot of people are like, oh, they have like a little GERD. I don't know if they'll be able to tolerate bisphosphonates. The only absolute esophageal contraindications to bisphosphonate is achalasia, esophageal varices. So don't pop one of those varices with bisphosphonate. And then Barrett's esophagus. Those are like the 3 like real esophageal things that should make you think not to prescribe a bisphosphonate for a patient. Bariatric surgery. So Cody talked about Roux-en-Y gastric bypass before. So if a patient has like a primary anastomosis of intestinal lumen, there's evidence that bisphosphonates can cause necrosis of those anastomoses. So you shouldn't prescribe a bisphosphonate in someone who's had bariatric surgery. And then anyone who's imminently going to have an invasive dental procedure, so because of risk of osteonecrosis of the jaw. When you're counseling a patient about taking a bisphosphonate correctly, this is like the hardest thing, right? is, so you tell the patient, pick a day of the week that you're going to take your bisphosphonate. And a lot of patients say, okay, I'm going to do Sunday. They should take their bisphosphonate on an empty stomach first thing in the morning with a full glass of water. They shouldn't eat anything else for 30 minutes, and they should stay upright for 30 minutes to prevent esophagitis. So duration of therapy for bisphosphonates is really important. And the reason why is there's a lot of evidence that show harm of continuing your bisphosphonate beyond the recommended duration of therapy, and that's related to atypical fractures. So this figure here on letter A on the left is showing you like the typical, femoral neck fracture that's going across the femur. And then in letter B, you're seeing this really, really pathologic, like clean break across the femur that is not normal. And that atypical fracture is much more morbid. It's very hard to repair that because the bone is like, over mineralized and stuff. So that's what happens when patients are on chronic bisphosphonates longer than they should be. So the recommended duration of therapy for an oral bisphosphonate is 5 years. The recommended duration of therapy for IV bisphosphonate is 3 years. In terms of repeating a DEXA, so it is recommended to repeat your DEXA in 2 years to assess treatment response. And then a clinical question that I've had before is like, once the patient has finished treatment, is there any benefit to repeating a DEXA? And the answer is yes, because if they still have not had adequate treatment response, or if they have severe osteoporosis, there may be other treatments that are available to them. In terms of side effects, don't forget about pill esophagitis, the atypical fractures that we talked about, and then osteonecrosis of the jaw. Okay, some questions.
Anisha, in the chat. First question, does osteoporosis equal an automatic referral to Falls Clinic?
No, you can do a lot of that stuff yourself. Yeah, I think only people with complex falls will really need to go to Falls Clinic, or if you think they would benefit from integrated PT within a clinic. That's one of the unique things about that clinic. But a lot of fall prevention, like you can do the counseling yourself in primary care.
And a question from Cody, what's your take on screening for vitamin D deficiency prior to screening for osteoporosis?
So you should make sure patients are vitamin D replete before starting, before obtaining your DEXA, because like if you're going to initiate treatment, you should make sure they're vitamin D replete. The way to do that, it would be reasonable to just start a patient on vitamin D for 3 months and then just make sure that their levels are replete rather than screening for deficiency and then checking again. Because you can be guaranteed that most patients are going to be deficient. So you might as well just replete them initially and then ensure that they're replete and then start treatment. Arita about the bariatric patients, it's for both, including IV bisphosphonates, there's that risk as well. So Sheila, IV bisphosphonates are okay for people who have esophageal contraindications. But the risk of osteonecrosis of the jaw and atypical fractures still exists for IV bisphosphonates. And once they're treated and if DEXA improves, did you come across any literature that their bone density will again go down after a certain amount of time? So I didn't specifically look at like 10-year, 20-year studies, but even after treatment in the first 5 years, there will be some decrease in their bone density after they come off. That is inevitable. But it won't come down at the rapid rate that it was before. Great questions, guys. Okay. Sorry, I'm kind of speeding through because there's some more stuff to get through. So hormone replacement, I think, is really confusing to me. I don't prescribe a lot of hormone replacement. So basically, big picture is hormone replacement is an off-label use for treatment of osteoporosis. You should only use use hormone replacement in women who are perimenopausal. So people who are more than 10 years out from menopause should not get hormones for osteoporosis. hormone replacement is really appealing therapy because it improves the quality of their bone, not just the bone density. So, estrogen is like major food for the bone. There are many contraindications that we learned from the Women's Health Initiative that preclude use of hormone replacement for osteoporosis alone. But, you can use a selective estrogen receptor modulator like raloxifene for similar benefits. So raloxifene has mixed estrogen agonist-antagonist activity. So it's an agonist at the bone and antagonist in breast tissue. So you can use raloxifene in postmenopausal women who can't tolerate bisphosphonates. We were talking about like people who can't tolerate it. Raloxifene is a reasonable choice. You can also use this as a preferred treatment for people who are high risk for breast cancer because they'll have some breast cancer preventative activity. You shouldn't use raloxifene if someone has a risk of clots. And most of the evidence for raloxifene shows prevention of fractures, specifically for vertebral fractures. Okay. Denosumab. So this is like a hot topic in osteoporosis, and I'll preface this discussion is in like the general population, and I have a note about denosumab in the CKD population. If you're thinking about denosumab in the cancer population, there's just distinct criteria. But basically, the osteoporosis field has really shifted away from denosumab. Denosumab is a rank ligand monoclonal antibody, which sounds really appealing because it's so targeted against, those the rank ligand on osteoclasts that resorb bone. But one of the long-term consequences that is borne out in the literature is that denosumab fosters this like upregulation of osteoclasts. So these osteoclasts like multiply after you introduce this monoclonal antibody. And while they're on denosumab, that keeps them at bay. But once you withdraw denosumab, there's like massive resorption of bone and very high risk of rebound fractures after you discontinue denosumab because all these osteoclasts have been upregulated while they've been suppressed by the monoclonal antibody. In terms of like when to use this, so you can use it in women who have severe osteoporosis and have a very like low life expectancy where you're going to commit them to denosumab for the rest of their life. You can also think about it in chronic kidney disease because denosumab is like very happily not cleared by the kidney. So a lot of people find that appealing for CKD, mineral bone disease. But there's a very high risk of hypocalcemia associated with use of denosumab and CKD, resulting in tetany, seizures, and arrhythmias. Teriparatide is an anabolic therapy that's a PTH analog that's indicated for severe osteoporosis and high risk of fracture. You can think about this also in women who have a contraindication or unable to tolerate bisphosphonates. You shouldn't use a PTH analog in someone who has primary hyperparathyroidism. If they have hypercalcemia as well, you shouldn't use this because there's increase of serum calcium with this PTH analog. There's also risks of gout and kidney stones, and the duration of therapy is for this is 2 years. Teriparatide was superior compared to risendronate in head-to-head trials, so it is considered like a superior drug to bisphosphonate. Romosozumab is kind of like the new hot medication in osteoporosis. It's a monoclonal antibody against sclerostin. So sclerostin is a protein that's secreted by osteocytes, which is what osteoblasts become when they enter the bone matrix. Sclerostin inhibits bone formation. So this is inhibition of bone formation, resulting in a net gain. The indications for romosozumab right now are women with severe osteoporosis or multiple fragility fractures, not a good candidate for other treatments, or lack of treatment response after bisphosphonate. So this goes back to your woman who you put on a bisphosphonate for 5 years, you got a completion DEXA that shows that they didn't really respond or they still have very severe osteoporosis, you can consider referring them to romosozumab. Romosozumab was superior to teriparatide for treatment after bisphosphonate. So like that woman who's completed bisphosphonate, there's evidence that shows romosozumab as your second agent is superior to teriparatide. People you shouldn't use romosozumab in are people with a high risk cardiovascular history. So if they've had an MI or a stroke, there's some cardiovascular risks that are thought to be associated with romosozumab, and the duration of therapy is 12 months. Don't have a ton of time to get into like CKD and osteoporosis, but I'll just leave it at, the pattern of osteoporosis is very distinct in CKD because of the calcium and phosphate dysregulation that occurs in CKD. There's this disease entity called adynamic bone that's treated distinctly than osteoporosis. And for that, like the treatment of choice is teriparatide. Just in general, like if a patient's GFR is above 30, you can treat them similarly to the general population, but less than 30, don't use bisphosphonates. Think about hormone replacement, which is like agnostic to their GFR, which may be a reasonable strategy. And then osteoporosis in men, think about hypogonadism as a contributor for osteoporosis, and think about where it might be appropriate to do testosterone replacement. Think about other secondary causes of osteoporosis that you might want to mitigate, and the rest of treatment is similar to management for women. A caveat that romosozumab is still kind of controversial in men because there's that concern about increased cardiovascular events. I have some questions, but I think we're running out of time. Is that right, Shri? Yeah, okay.
We're running a little short, yep.
Yeah. So thanks to Susan Ott, who is like the UW resident expert in osteoporosis and was one of the original like PIs for the trials that showed alendronate was efficacious. And then my friend Pooja, who's one of the ortho R3s who gave me her surgical perspective about fracture. And references and short amount of time for questions.
Yeah, I mean, people can take a break. We'll come back at 9:55 for the next talk. But there are a couple questions in the chat, Anisha, if you wanted to take a stab at them.
Awesome. Okay. Alwea is asking, recommending screening patients for premature ovarian insufficiency earlier than 65. Yes, so that's an entity I think about screening a patient earlier. And the right age to screen them for is also challenging, and thinking about like how long they've been postmenopausal. Generally, the teaching I've done is like more than 10 years out for menopause, and you can think about screening them. So if a woman went through, it was premature ovarian failure in her early 40s, think about it in their mid 50s. Adynamic bone disease is complicated. I really like this table that Susan Ott shared with me that shows like the difference of mechanisms of CKD, mineral bone disease versus like run-of-the-mill osteoporosis. And a lot of it comes back to dysregulation of PTH, calcium, and phosphorus. So in adynamic bone, bone density actually isn't really predictive of fractures. And the reason is because of like these like microenvironments of calcifications that is associated with CKD. Adynamic bone is, this osteodystrophic entity noted in dialysis patient where there's just like frozen bone turnover and decreased cellularity of the bone. So the ways to check for that is, you can obtain a DEXA, but the density isn't really predictive of their fracture risk. And it's more related to their calcium, PTH, and phosphate balance, which is managed usually by the nephrologist because these are all dialysis patients. Sasha's asking, can you do bisphosphonates twice, take a break and do 5 years? So that's a great question. There is a lot of research going on that about bisphosphonate holiday. And I don't know. There's like a lot of like ongoing studies about that. But right now the teaching is, 5 years and you're done, and try not to go back there. But if a patient has like very severe disease, severe risk, I have seen people like do a 5-year holiday and come back to it. Okay, I think those are the questions.
Awesome. Thank you so much, Anisha. This was a fantastic talk. If folks have additional questions, feel free to reach out to her. But otherwise, we'll see you back at 9:55.